Welcome to the first session of the Johns Hopkins Infectious Disease Training Program HIV Curriculum. The first session is going to be covering HIV epidemiology and diagnostic testing within the United States. I'm Natasha Chida. I'm a third-year Hopkins Infectious Disease Fellow.
And I'm Robin Mckenzie. I'm one of the ID faculty members.
All right. So we have no relevant disclosures. And session objectives. So at the end of the session, participants will be able to describe the global and U.S. burden of HIV disease, name groups with the highest rates of HIV acquisition in the U.S., describe the HIV care continuum within the U.S., name current available HIV diagnostics for the diagnosis of HIV disease in the U.S., and interpret the results of HIV diagnostics for the diagnosis of HIV disease. So just as of 2013, about 35 million people were living with HIV globally. And of those, less than half were on treatment. And there have been 39 million deaths totally since the HIV epidemic began. More pertinent to us, as of 2011, 1.2 million persons in the US were living with HIV, of which about 13% were unaware of their infection. And the annual incidence is estimated to be about 50,000. I think the two numbers we felt were most pertinent to folks were 35 million people living globally, 1.2 million people in the US. So this is a slide from the CDC, and it's looking at rates of adults and adolescents living with diagnosed HIV infection. These are folks who actually know they have HIV. And as you can see, there's variations depending on the geographic location where folks are. So it seems like the Northeast and the Southeast seem to have the highest rates per 100,000. Total rate in the country is about 352 per 100,000, but as you can see, there are significant differences depending on where you live. So in DC, for example, there's about a rate of 2,800 per 100,000, whereas Maryland is 631. If you look at Baltimore City, we're actually very close to DC. We're at about 2,400 or so. So we have a significant burden of disease here. Something that's been getting a lot of traction in the last, I guess it would be about 5 years or so, is this concept of the HIV care continuum. So early on in the HIV epidemic, there was a lot of focus on testing, diagnosing, and what we've been seeing is that we are getting people diagnosed, but we're not necessarily getting them virally suppressed, which is our goal. So the care continuum includes different steps, one of which is first a diagnosis of HIV infection, getting linked to care, then getting engaged in care, getting prescribed therapy, and then being virally suppressed. Look at people who are diagnosed with HIV infection in 2012. About 50% are receiving care. Of those, 50% are prescribed ART and 41% are virally suppressed. So even when we're diagnosing people, we're not really suppressing them with ART, which is, again, what our goal would be as HIV providers. And I think this is something that's receiving a lot of focus in terms of our national strategy because, yes, we can diagnose folks, but we're not actually getting them to the point where we want them to be. And I think there's going to be a lot more focus as the year comes on what we can do to actually get people linked to care, retained in care, and on medications. Okay, so if you look at people, diagnosis of HIV infection among adults and adolescents. So the first map we looked at were rates of HIV. This is looking at just diagnosis of new HIV infection in the country. It's pretty much the same locations where this seems to be occurring. So the total rate in the country is about 18 per 100,000. Maryland is about 43, DC is 109, and Baltimore City's rates are around the same as DC's. And again, it's the Northeast and the Southeast that are having the most new diagnoses of HIV infection in the population. Then if you look at deaths of persons with diagnosed HIV infection, again, African Americans have higher rates of death compared to other groups with a rate of 21.1 per 100,000, which is significantly higher than other populations. If we look at Hispanic Latino persons and Caucasian persons, which are the two second and third groups with the highest rates of HIV infection, it's much lower. It's 4.9 for Hispanic Latino persons and 2.7 for a white person. So African Americans are having more rates of HIV diagnosis, more rates of AIDS diagnoses, and have higher rates of mortality. So just a summary of epidemiology, most people in the US who are living with HIV are diagnosed, most people are not on treatment, and most people are not virologically suppressed. HIV is being diagnosed most among men, African Americans, and persons aged 25 to 34 years. And areas of the U.S. with highest burdens of HIV incidence and prevalence are the Southeast and the Northeast as well. So we're going to move on to testing, unless anyone has any questions. Okay. So now just getting into diagnosing HIV infection. So this is specifically referring to diagnosing new HIV infections as opposed to follow-up testing for folks who are already in care. So why do we want to diagnose people early? So there is some data that during acute infection, high levels of virus are present in the serum and genital secretions for up to 3 months. And rates of transmission during acute infection seems to be 26 times higher than during established infection. And it's estimated that acute infection may account for 10 to 50% of all new transmissions. That's a wide range, but even 10% of new transitions is pretty high. And so current guidelines actually recommend treatment for acute HIV infection, which was a new recommendation that has come out over the last few years, mainly because of this idea, well, multiple ideas, but one of the key ideas was that decreasing transmission through treatment. Other issues is treatment of acute HIV infection seems to improve markers of disease progression. So it might decrease the severity of acute disease, but also slow disease progression, so slow decline in CD4 count. It might reduce the viral set point and the size of the viral reservoir in white blood cells. And it decreases the rate of viral mutation by suppressing replication and preserving immune function. So there's a population benefit to early treatment, but there's also a patient-specific benefit to early treatment by hopefully producing better long-term outcomes by treatment. A lot of these are smaller studies, and studies in the short term. We don't have necessarily long-term data that's proven that early treatment during acute infection improves prognosis, but I think these smaller studies that were enough to make people change the guidelines that we should be treating people with acute HIV. So this is why we want to diagnose HIV.
Also, the move is toward treating everybody, of course, and that recommendation has become stronger with the results of the START study that have just come out that show their benefits to treating even with CD4 counts higher than 500. So this is also part of that push to get everybody on treatment.
Mm-hmm. So just going through, we don't use a lot of these tests now, but just going through the different iterations of HIV diagnostic tests. The first generation tests were what we started with and were initially recommended back in the mid to late 90s. And the CDC actually only changed these recommendations in 2013, actually. So the first generation tests were basically taking antigens of viruses that were grown in culture, combining that with a sample from the patient, and then adding in labeled anti-human IgG. The problem with this was there was a lot of cross-reactivity between cellular protein contaminants, and it was also misclassifying patients who had HIV-1 versus HIV-2. We'll get into why that's important, but misclassifying folks with HIV-2 as having HIV-1 can be problematic because patients with HIV-2 are intrinsically resistant to certain ART and have different prognostic implications. And so mislabeling them resulted in the development of second generation HIV tests. The difference with this is these were synthetic antigens that were being used rather than actual antigens that were virus that was being grown in culture. They're also added in a protein A which seemed to bind to IgG with higher affinity. So this improved the sensitivity and also improved the specificity of HIV testing. And some of the second generation tests were able to differentiate between HIV-1 and 2. I'm sorry, that's a typo. But not all of them were. So just going into when these tests are detectable, because I think this is what comes up with us a lot as fellows. So HIV RNA is still the test that can detect HIV infection earliest. It can detect it within 10 days after infection. The P24 antigen is detectable 2 to 3 weeks after infection. So basically 4 days after the RNA is detecting it, up to 21 days after infection. This is the fourth generation test. IgM antibodies are detectable approximately 3 weeks after infection, which is seen in the third and fourth generation tests. And then IgG antibodies, which were our initial first generation tests, detectable between 4 to 7 weeks after infection.
Period. That's the first 10 days or so when there's no marker in the blood. So that's before the viral RNA appears. But since the incubation period for acute infection is generally 2 to 3 weeks, by the time someone is symptomatic and is sitting in front of you, an RNA test should be positive.
So the benefit of the fourth generation tests, if we looked back at the third generation immunoassays and people who actually had a reactive nucleic acid test, they were reactive in 20 to 37% of patients. So they were missing a lot of acute HIV. because of when they were being used. If you look back at people who are not reactive, the fourth generation tests are still only doing 62 to 83%. But again, part of this is just the timing of when a NAT will become positive and the timing of when the antigen antibodies will become positive. But the fourth generation tests really do pick up a lot more acute HIV than the rest of the other tests do. Yeah, window periods, as Robin mentioned, the eclipse period is after infection where no laboratory markers are consistently detectable. And then there's a seroconversion window period, which is the interval between infection and the first detection of antibody. So not the first detection of P24, the first detection of antibody. That is seroconversion. And so if you look here, this is the eclipse period between 0 to 10 days. And if you look at the seroconversion window, it's 0 to 21 days or 3 weeks or so, basically. And then if you just look at the interval between HIV RNA and the P24, it's about 4 to 11 days. And we'll get into the clinical implications of that in a bit, which is about at least 3 to 4 weeks. Okay, so the CDC recommended testing algorithm, which is new as of 2013, the first time they were changed after first generation tests were recommended, was to start with a fourth generation combination immunoassay that detects both HIV-1 and 2 antibodies and an HIV-1 P24 antigen.
So this is a positive would be a reaction to any of those three components, and you don't know which component they are reacting to.
Right. And any reactive specimen then undergoes testing with an immunoassay that differentiates HIV-1 and HIV-2. If specimens that are reactive on the initial screen are then non-reactive or determinate on the follow-up differentiation, then you would order an HIV nucleic acid test. Of note, there are no FDA-approved HIV-2 nucleic acid tests. So if you're going down that route, you'll only pick up HIV-1, you will not pick up HIV-2.
But the idea here is that we don't have much HIV-2 in this country. It's very prevalent in parts of West Africa. But if you're suspicious and have a patient who's from there or who may have been infected by somebody from West Africa, you'd be more interested in HIV-2. And there is a lab out in Seattle that will do the nucleic acid testing. I have a patient from West Africa and have been able to send his viral loads there to get tested. And like a lot of HIV-2 infected patients, the viral load is very low, single digits or undetectable at times without treatment.
Come up with this is what we're talking about. So why differentiate between HIV-1 and 2? So it's uncommon in the U.S. Less than 200 cases were reported through 2009. The majority were from West Africa, but there were about 12% either from India, North America, and Europe. It's important to diagnose because all NNRTIs and some protease inhibitors are intrinsically not effective against HIV-2. So if you put a patient on one of those regimens thinking you have HIV-1 infection, they will not respond. Just in general, the first generation tests failed to detect about 15 to 53% of HIV-2 infections, which again was a problem because of ART that was being started. And then the other thing to know is that HIV-2 RNA testing, we do have some lab-based tests and homegrown tests that aren't FDA approved. Those are undetectable in about half of HIV-2 infected patients. And for that, testing proviral DNA may be required, but that's a send-out special lab test that's not necessarily part of an algorithm or an approved test. Yeah, so even here you actually have it in part of the algorithm where both the antibodies are detected. So just a summary of diagnosing HIV, the first detectable marker of infection is still RNA, which is positive 10 days after initial infection. The fourth generation assays have improved sensitivity compared to the first through third generation assays and can be positive 2 to 3 weeks after infection. And therefore, the recommended algorithm from the CDC at this time is to start with a combination immunoassay for HIV-1 and 2 antibodies and an HIV-1 P24 antigen. Again, this test, if positive, will not tell you which one of those is reacting. It's just that we know one of them is. If that initial test is positive, you then undergo differentiation testing because you want to diagnose HIV-2 because of intrinsic resistance to some ART. Okay.
This concludes session 1 of the Johns Hopkins HIV Curriculum. This was HIV Epidemiology and Testing in the United States with Natasha Chida and Robin Mckenzie.